All right, so we're going to be going over clinical interviewing in accordance to psychological testings. And pretty much your chapters 4 and 5 of listening skills will be covered, as well as some other information in terms of how you would use clinical interviewing psychometrically. So some of the things I'm hoping that we'll be able to cover and will be helpful for you would be first, knowing the difference between what our skills as a therapist would be compared to our attitude when we're meeting in front of clients. We're going to have to adjust and work with our clients in a way that our attitude would be appropriate for both collecting data about the client, but still keeping the client in mind. Um, Organizing and being able to take time to use our listening skills. And there's 3 general areas that we'll be going over. We'll also be talking about non-directive type of listening behaviors with our clinical interviews that looks at when it's appropriate for silence, how we would utilize paraphrasing, how we would take care of clarification, as well as reflection of feeling, summarizing, and then how we change our listening skills that will be in accordance to, like, with gender, how male clients may listen differently than female clients, and as well as looking at the different cultural backgrounds that we would have to consider. So starting off first, let's take a look at what do we mean when we're saying therapeutic skills to therapeutic attitude. With the skills, we know that that's our technical skill set. And with the technical skills, what we're taking a specific look at is how we facilitate the session in terms of when we are allowing a client to speak, when we are interjecting ourselves, when we're providing helping as far as prompts, micro skills, looking into what the client is saying specifically, as well as how we are able to facilitate the clinical interview itself. Attitude is you, how you are in terms of uh, a therapist, and in this case, who's going to be performing psychological testing on a client. How is it that you are portraying yourself to your client? We're going to talk about how Rogers, with humanistic behaviors, is keen on client-centered type of approaches in which our listening skills should be demonstrated as non-judgmental, as well as always helping to establish rapport during your interactions with your client. Now, I'm going to play a video of Summers Flanagan talking a little bit about the therapeutic attitude. And what I'll ask, hopefully it will not sound too garbled. I'm finding that when I'm recording at the same time, that it gives a echo, so to speak. So hopefully it'll be clear enough for you to understand. I will also include this on the page by itself in case you're not able to understand it. But I'm going to go ahead and play this now.
This chapter is more than skill development. It's also about embracing
This
the
chapter is
proper
more
attitude for the
than
working
skill
alliance.
development.
Which
It's
is why
also
we start
about
the chapter
embracing the
with Carl
proper
Rogers.
attitude for the
For
working
Rogers,
alliance.
I
Which is why
think
we start the
having the
chapter
right
with
attitude
Carl Rogers.
was
For
even
Rogers,
more important than
I
skills.
think having the
Right,
right
and you know, it's like with
attitude
empathy,
was
it's more
even
than
more
just doing
important
a
than
reflection
skills.
that says,
Right, and you know, it's
you
like
feel
with
sad.
empathy,
It's actually
it's more than
saying you
just
feel
doing a
sad
reflection
and
that
allowing
says
yourself to
you
resonate
feel
or
sad.
feel with
It's actually
some
saying you feel
physiological
sad
sense
and
of what the
allowing
client might be
yourself to
feeling.
resonate
In
or
fact, there's
feel
even
with
some neurological
some physiological sense of
evidence
what the client
for
might be
empathy,
feeling.
right?
Right. In
Yeah,
fact,
it's
there's
too bad
even
we don't
some
have a
neurological
portable
evidence
MRI
for
that
empathy,
would
right?
Yeah, it's too bad we don't
allow
have
us to
a
see what's happening in our
portable
brains right now,
MRI
and
that would
I'm starting to have a neurological
allow us to see
response
what's
or
happening in our brains right now,
neurophysiological
and
response to your
I'm starting to
negative
have a
attending behavior
neurological
right now.
response or neurophysiological response to your
Rita?
negative attending
Oh,
behavior right
were you?
now.
I'm sorry. Did you say something?
Rita?
So, there's this range of different behaviors that you can use that are kind of off-putting, and
So,
I know this
there's
is
this
one
range of
that some
different
people might
behaviors that
find
you can
not
use
so
that are
good.
kind of off-putting. And
Right.
I know this
Well,
is one
there
that
are
some people might
others
find
yawning.
not so good.
You can look
Right.
at your
Well,
watch.
there
There's
are
all sorts of things
others
that might be
yawning.
possible.
Looking at your
can,
watch
look
is a
at
pretty
your
clear
watch.
message. One of the
There's all
reasons that
sorts of
we...
things
And
that
interrupting.
might be
Yeah.
possible. Looking at your
Well, we
watch
did that
is a pretty
before.
clear message.
I'm doing it
One of the
again.
reasons that we...
And interrupting.
Yeah.
So
Well, we did
interrupting
that before.
and a lot of other
Doing it again.
behaviors are good examples of what
So,
not to do. Interrupting is especially interesting because it involves a power differential. Whoever interrupts and takes the floor is the one exercising power or control.
Right, and it's really a message. I think what I'm saying must be just a little more important than what you're saying.
Right, and it's really a message.
Now, another point about
I
this
think what
really
I'm
is
saying
somewhat
must be just a little more
related to
important than what you're
cultural differences.
Now, another point about
And
this
so
really
if
is
I'm
somewhat
leaning forward
related to
and I'm
cultural
starting to, maybe
differences.
you're talking and I'm
so
just
if I'm
listening
leaning
with
forward
great
and
intensity to
I'm
what you
starting
say,
to- maybe
and I'm
you're
nodding,
talking and I'm just
and
listening
maybe I'm
with great
enthusiastically
intensity
tracking
to
and
what you say.
paraphrasing,
And I'm nodding.
and you're backing up.
And maybe
I
I'm
need to be in
enthusiastically
tune with how
tracking
you're
and
responding to my
paraphrasing.
listening behavior, because
And you're
it's
backing
really
up. I need
it's
to
really
be
my
in
fault.
tune
It's not the
with how you're
client's fault
responding
if the
to
client
my
feels
listening
uncomfortable.
behavior, because
I need to
it's
make
really-
some adjustments
it's really
to
my
help the
fault.
client feel
It's not the
comfortable
client's fault if the
with
client feels
my listening
uncomfortable.
behavior,
I need to make
so
some
that the
adjustments
client
to help
is
the client
able
feel comfortable
to be open
with
and
my
talk
listening
freely.
behavior, so that the client
In this
is
next
able
clip, John
to
is meeting
be
with
open
Tess,
and talk
and
freely.
early in the session, she shows
In this
some
next
emotion.
clip, John is
John
meeting with
notices it,
Tess,
and he
and
also
early
gives
in
her
the
a
session,
frame
she
or an
shows some emotion.
explanation for why
John
the
notices
emotions
it,
might be coming
and he
in.
also gives her a frame or an explanation.
So if
for
we
why
have
the
a really good
emotions might
meeting,
be
we will
coming
have talked
out.
about your family.
Yes.
And so I am going to
So if
give you the
we
lead
have a
and
really
let
good
you
meeting,
talk about
we
the
will talk
family
about your family.
in whatever
Yes.
way you
And so
want
I am
to.
going
Okay.
to give
On
you the
occasion,
lead
I
and
might
let you
grab
talk about the
my
family in
clipboard
whatever
and
way
take
you
some
want
notes.
to.
Okay.
But
On
I might also
occasion,
try
I
to keep
might
most of it
grab
in
my
my
notes,
head.
my
Okay.
clipboard,
Okay.
take some notes.
So what would you
But I
like
might
to,
also
what
try
would
to
you like
keep
me to
most of
know
it in
about
my
your family
head.
to start
Okay.
with?
So what would you like to? What would you like me to know about your
Where to
family?
start?
Yeah.
I'd probably start with my son.
Okay.
Where to start?
I had him
I'd probably
when
start
I
with my
was
son. Okay.
20.
I had him when I was.
I had
20.
him not by my husband, through
I
someone
had
else.
him
But my husband has
not
raised
by
him.
my husband, through someone else.
I
But my
found out
husband
that
has
he
raised
had autism and ADHD when he was
I found out
almost
that
3.
he had autism and ADHD.
I started him on medication at that
almost
young
3.
age.
Yeah.
So he's been on it
I
for
started him on medication
going on his second year.
at young
Almost 2
age.
years.
Yeah,
Yeah.
and
So he's been
done
on
very
it
well with
for
it.
Okay.
going on his second
At
year.
first it was a challenge
Yeah,
because we
and
tried like
he's done very well
5
with it.
different types of medications
At first
before
it was
we
a
found
challenge
the right one.
because we tried like 5
but
different types of medications before we found
The
the right
doctor
one.
said that as he grows older,
but
we're just going to keep going through that
The
cycle
doctor
where we have to
said
switch up
that
his
as he grows
medication.
older, it's just
Yeah,
we're just
where
going
you
to
have
keep
to
going
figure
through
out
that
which
cycle
one
where
is
we
gonna
have
work
to
now.
switch up his medication.
Yeah.
Yeah, where you have to figure
So
out
of course I
which one
notice
is
as
going to
you
work now.
talk about your son that you have some emotions.
Yeah.
So of course I
around it.
notice
Yeah.
as you
lot
talk
built
about your son that you
through
have some emotions. Yeah,
His
around it.
going on
A
his
lot
5th year.
built
Yeah.
through.
Yeah, and
Right,
can you
going on.
put some words to describe what kinds of
Yeah,
thoughts and
and
feelings
can you
that you're
put
having?
some words to describe
I have a lot of
what
stress.
kinds of thoughts and
Yeah.
feelings that you're having?
A
I
lot
have a
of
lot
worry.
of stress.
You just take that. And
Thank you. Sorry. I try not to cry,
A lot of
but
worry.
it's my son.
Thank you.
He's my
Sorry. I try not to cry, but
I guess the
It's
tears
my
are
son.
really a sign of
He's
how
my
much you care about
Yeah,
him.
how much I care about him.
I guess the tears are really a sign of how much you care about it. Yeah, how much I care about it.
All right, so he was able to get a few different examples in terms of listening and how you might be able to demonstrate to your client ways to listen, both correctly and incorrectly. One of the things in terms of when we're doing our clinical interviews for uh, psychometric purposes is taking this information and utilizing it in our assessment process. Be that if we're doing it for treatment planning or if we're going to go into deeper, further psychological evaluation, the information that was provided can give you great details depending on what the referral question was. Suppose the referral question was actually for her son and not her. How would you be able to utilize the information she provided based upon your listening skills? What was it that you would be able to grab from it is being able to start to dissect and break down things that you would need to know in order to further test the child, for example, if it was the child that we were going to be testing. So, for example, she mentioned about him already being diagnosed with autism and ADHD. She talked about the fact that he's been on several medications and that the pediatrician has mentioned that this will be changing ongoing till they find the right medications that will work best for the child. That's information that really you're able to now take and place within your evaluation in terms of how you would go forward on what instruments might be best for you to use. If there are, with the medications, you may start asking questions in regards to what type of affect the child will be going through. Is it going to be any type of lethargy or any hyperactivity because the non-compliance of medications? I mean, the list can get way beyond, but when you have that and you're taking time to listen, and this approach is actually a non-directive stance in that the Summer Flanagan, he allowed her to provide him with a majority of the information. Now, there's positive and negatives with that, and we'll keep talking about it and going through it. But this was an example of things that you would hope to see in his interviewing with her on being non-directive in terms of your listening skills. Now, at the start of the video, you notice that the Summer Flanagans was demonstrating some behaviors that you want to try to avoid, and it's so inadvertent at times that when we're meeting with our clients, in terms of when they're speaking, we may start looking and doing things that we really shouldn't have. And I know I have been guilty of that, and I have to work with that. It's something that we have to practice. Body language is a big part of your clinical skills in terms of how you present, whether or not you are truly involved with the client. So we want to be able to take note of that and think about different things that you might have found yourself doing and not realizing it. In hindsight, looking back now at times that you've met with clients, have you found yourself where your body language wasn't erect, or were you too forward, depending on the cultural significance? Those different type of things we have to become aware of on a continual basis. It's something that you will be doing throughout your entire career. But the importance of it is where if you feel like the person is becoming uncomfortable or feeling pushed, that's going to tear at your rapport building. And the less rapport you have with an individual, the less open they will be in terms of particularly collecting data for your psychological assessment.
This chapter is more than skill development. It's also about embracing the proper attitude for the working alliance.
All right, so now let's look at thinking about non-directive listening. Are you really being active when you leave it up to your client? When we talk about direct listening methods, we know that this is more of a measure that's observable in terms of clinical interviewing, because it's more where you're giving questions that the client's going to specifically answer. Whereas when we're speaking about indirect methods to be able to assess opinions, beliefs, or attitudes, this is where there might be sometimes we feel that it's confusing. Think about when we conduct and do a WACE. That's pretty much a direct type of measurement where direct listening occurs beforehand, because you're going to prompt your client's performance in a way of providing them with the specific questions that they would need to answer. Whereas with an indirect measurements, here you're going to be exploring the client's experiences that will help to ascertain the results through the psychological test and what directions your psychological test will take. So more than not, direct listening will have more weight than it would than in terms of thinking about the different theories like classical testing theory or item response theory. But when we're talking about a non-directive listening approach, that can really might not sit as well, because it's much more subjective somewhat in terms of collecting data. So your psychological testing, you have to really consider time constraints. When you're doing non-directive type of listening, it's where you're giving the floor to the client and allowing the client to say everything and anything they feel is going to help you understand them better. But these questions can be provide some great data that's going to be utilized that you might get better from indirect listening than you would from directive listening. So some things just to keep in tail and understanding is that we need to make sure we have healthy boundaries. And Roger's approach is, of course, going to be a client-therapist type of relationship where the client is emphasized more than the therapist would be. Our practices about active listening is the main thing and main ingredient will be paying attention, taking time to let them know through paraphrases, through reflection. And when I say reflection, I'm also speaking about reflecting how it made you feel to hear about it. That's where we talk about genuineness and the non-judgmental. It's important that a person is feeling validated, and that can be reflected in how you say it. You're also going to want to make sure that everything that you say has a true meaning. That includes your body language. So if I'm like, well, let me tell you more about this this chapter, you can kind of see based upon my body language right now that I might be where I really don't care. Whereas me allowing myself to sit here before you, sitting up straight, my couch is behind me, as you can see, so I'm on the edge of my seat to keep myself direct and erect, so to speak, allows you to understand that I am really focused on trying to convey information to you. So it's important that the meaning behind our words as well as our body language is going to reflect the true stance and nature of what that clinical interview would be about. Avoidance of judging. You don't want to judge the client. And guess what? I'm going to also include you don't want to judge yourself during the time you're with your client. A lot of times, especially when we're talking about early career psychologists, in terms of their interviewing skills, sometimes there's unsureties. We're not sure we're taking the right direction. You kind of want to make sure that you have a full awareness of your abilities and of what you're doing so that it doesn't come out within your session, within the interview, because the lack of confidence will bubble up and people will see and notice. So you want to look into yourself at all times to make sure you feel confident about your level of competence. So in non-directive listening, This is not a time that we would do any kind of advisements or in times of making decisions. And particularly when we're doing psychological assessments, at the initial clinical interview, you're gathering information, meaning I'm not going to tell the client, well, from what I'm hearing from you right now, you are definitely showing symptoms of depression. No, this is why we're here. We're here to decide, to discover what's going on with you today. I'm going to be asking you questions that hopefully will help us to discover that. There may be some tests that I have you take, or, there'll be questions, and I might have you completing some forms that's going to help me to better understand what's going on with you. So at the very start, we want to be clear, of course, but we don't want to provide a diagnosis before we've actually done everything within our psychological assessment to give one. And of course, you want to try your best to be real, being authentic and transparent, and know when to accept when you show or talk about both positive and negative emotions. What does that mean? That's meaning that having the client understand that we're here to help them, but it's going to be a realistic situation. It's not just going to be, a lot of clients will think that I'm supposed to automatically make them feel better. And sometimes just listening, and if we're talking about a non-directive listening approach, sometimes my listening, even if I'm paraphrasing, it may make them feel like, okay, well, you're not telling me what to do. And in terms of psychological assessment, we're not supposed to tell them what to do. We're supposed to be doing exploration, so to speak. So these are some things you want to keep in mind. All right, so before we continue speaking about listening styles in terms of clinical interviewing, I did want to break in between and kind of look at some of the psychometric principles that will be involved in the screening process for psychiatric disorders. There's a real appreciation for the use of psychometrics with psychological screening, and a lot of it is dependent upon our understanding of how involved the psychological measurement really is in our process. There are general principles that really underlies psychological measurement that's not really any different from things that we use in terms of the scientific measurement. A major difference, though, is how we would distinguish between a psychological measurement from other types of measurements that's used, like for objects, for example. So basically, we work through a hypothetical type of construct, whereas in measurement of physical sciences, that's more about the tangible type of things that we look at, where we're measuring based off of ratio scales or true zeros and equal intervals and so forth. And you could think about like weighing ourselves or looking at the velocity, etc. But in terms of quantifying a hypothetical construct, like if we're talking about suicidal ideations or anxiety or depression, then measurement is really going to be more ordinal and used with interval type of scales, and that most times is kind of more difficult, and it's not as crisp or concise as if we was using a larger type of measurement tools. There would be a larger error of measurement based off of that. So psychological measurement, it's really not less scientific because of this distinction, but it is more a precise measurement in terms of physical sciences. So the first thing, of course, we need to know in everything that we utilize, is it reliable? When we're talking about reliability for scientific measurement, we know that it's based more on the consistency of being able to replicate, and as well as concerns to the degree of how we replicate toward a particular measurement. Think about what degree would a screening measure provide in terms of gaining those same type of results through re-administration a week later? Are we going to see the same results? So suppose you use the BDI with a client in terms of their measuring the level of depression. Are you anticipating to see the exact same results? It might be, but you have to wonder whether or not that tool will still be useful in terms of giving you that type of data. So we have to wonder also, what extent would myself compared to you, say we're two clinicians and we're doing a screening process, and what would we be looking for? So how is it in terms of when we're making judgments on a psychiatric rating scale, and would we agree with our results if we saw different results? So more or less, it's probably going to be different. So would we say that reliability is merely just a thought of what our thinking would be in terms of a measurement of error? Or is it going to represent that proportion of a variation within the measurement? That being that it's due to a true variation from the attribute under a particular study opposed to being random or a systematic type of error variance. We see reliability as a conceptualization, that being that it allows us to see the ratio of a true score variance within a total measurement variance. It allows for us to be specific in terms of precision of the measurement, thereby allowing us to set theoretical limits of measurement validity. And speaking about validity, what we're looking at here is just as important as reliability, because it allows us to understand the consistency of the measurement tools that we're dealing with. So here, validity will reflect more of the essence of what we're trying to measure in the first place. That degree in which the instrument that we're using will hopefully measure what it was designed to measure in the first place. It allows us to be specific in terms of knowing which instrument to work with. Like if we're talking about depression, that we already understand through evidence-based theories that the BDI would be a very useful tool for us to utilize. It's going to work with that specific attribute, which is depression, and it allows us to get an understanding in terms of the extent from that inventory of what would be capable in terms of discriminating against those that might be depressed compared to those who are not. So when we are establishing validity in the utilizing of a screening tool, it's going to be a more complex and programmatic type of instrument to allow us to determine whether reliability will be there in terms of theory. So even though the validation process involves a lot of different types of validity, the main one that we want to consider would be the predictive validity. And that's because with predictive validity of an assessment tool, it's going to hinge on that correlation of the agreement with an external reference criterion. Think of as it being a gold type of standard, okay? When using screening tests, it's going to be the external type of criteria that'll usually take form of like comprehensive laboratory or clinical type of diagnostic evaluations that will hopefully establish the presence or absence of the condition that we're seeking or trying to understand. So it's really important to have a good understanding about predictive validity in terms of the realization of how it's going to be specific in nature to the attribute that we're trying to measure. So for us to be able to look at a particular screening test being valid would generally have little or no scientific meaning or validity only on specific predictive purposes. Most of all, in looking at this, we see psychological tests being employed for screening for psychiatric disorders. And it has to be validated specifically in terms of those diagnostic conditions that's going to be designed to predict whether or not a person is depressed or not. So those are the two areas in talking about reliability and validity. But we also have to take a look at how does this particular instrument go across generally. So when we're talking about generalizability, just like with reliability and validity, it's important as a psychometric type of characteristic for test instruments in terms of psychiatric screening. There are so many different clinical conditions and manifestations that we might be looking at systematically that is altered or different based upon one's age, one's sex, one's race and cultural backgrounds, in terms of absence of if there's any type of comorbid illnesses present, that being medical or mental illnesses. And even when we have the validity coefficients, like if we're looking at sensitivity and specificity, excuse me, here we're talking more about how it's established in terms of a particular test that's going to be relative to that diagnostic question or condition. And it can show variability considerably in new samples, particularly if we're looking at demographics as well as some health characteristics, or if we're looking at a new cohort that's demonstrating a significant difference from the cohort that was first looked at from a test instrument that we wanted to use that has been validated. So now we're going to just talk a little bit about some issues that can be found in the methodology in terms of screening for the psychiatric disorders. There's been many who argued that there's different merits in regards to self-report versus a clinical rating and from the clinician. And pretty much a lot of this evidence really suggested that the two techniques do have its own strengths as well as weaknesses within the same magnitude. So there hasn't been, as to say, an approach that would function more effectively overall in terms of when we're speaking about screening for psychiatric disorders. So these situations in terms of screening situations have to be independently assessed as well as weighed to try to determine which modality would be best suited for the particular client you're working with. Traditionally speaking, the self-report inventories, they have been more frequently used rather than clinical rating scales. And that's probably because self-report modalities of measurement really fits better in terms of screening. Self-report measures are brief, they're inexpensive, the client, they are more accepting of it, and these type of facets helps to improve cost efficiency as well as the cost-benefit ratio in regards to measures. The self-report measures also can be transportable. You don't have to worry about big old cases. I mean, you might have something that's plain and simple that can be found on a sheet that's rather simplistic but have great detail. And it can be held within a variety of different settings. It allows you to minimize the expenditure of time and effort professionally. So in terms of administration, scoring, as well as evaluation, there's little input as far as professional of what the clinician can do or have to do. So with our technology today and being able to utilize computer technology, it allows for us to be able to adopt the approach even simpler, because we can now use computer administration as well as scoring, which reduces that time again that would be involved. Finally, when we look at the biggest advantage in terms of self-report, we have to also look at the fact that the self-report is completed by that client who's going through the situation at hand. So the respondent, their responses is coming based off their thoughts and their feelings. Now, a clinician, no matter how well skilled we are, will never really know the actual experience of the client. But instead, we can be satisfied with approximations and be able to do deductive reasoning in terms of representation of those situations. Last but not least, the self-report is going to also represent one of the best potential sources in terms of error. That would be client bias in terms of reporting, because the test respondent, or in this case our client, would actually be providing us the information, which gives opportunity for the clients to be able to be conscious or unconsciously distort within their responses that they give. So even though there might be some client biases, it gives us opportunity to see the level of honesty that's added, as well as whether the client is withholding. And empirical studies have been able to indicate that response distortions that represents a problem only in situations in which there might be some personal gain provided through such distortions or falsehoods given by a client. Otherwise, generally speaking, client bias is not going to be a major source to it. We won't see that much biases in it. We also have to take a look at the possibility that when there are response sets, like when someone acquiescents or attempts to provide an impression, that they would result within a systematic type of response distortion. That being, the effects would have little error variances in particularly realistic clinical situations. Now, the greatest limitation of self-report do come from the inflexibility of the format that's going to be provided. And the exception to that would be, there's some few tests that are conducted online that has branching logics attached to it, in which this is a line of questioning that really can't be altered or modified as a result of how the client would respond to previous questions. And then there's also responses that we can appreciate and utilize. That being, when we're face to face with a client, we have the facial expression. If we're using telehealth, we're in that situation now. And say, for example, although we are not doing assessments through telehealth, but if you were, and you were on the phone per se, you might not have their facial expression, but you might be having the ability to use the tone of voice, the attitude of how they respond to questions. Those are some of the cues that we can utilize in terms of cognitive and emotional status of the client, which, they're not real important facets to the data that we're trying to collect, but it still will give you the tone of how to approach and what questions would follow next. So because there is inflexibility, it kind of pushes out to the fact that clients they have to be literate if we're utilizing the computers. In order to be able to read, they have to understand what they're reading. They have to understand the questions. There are items like the brief psychiatric rating scale, or within our clinical interviewing, that would give us that alternative to using self-report instruments that's designed to screen the psychiatric disorders. Now, in terms of the clinical rating scale, this brings into the point our professional judgment as a clinician in terms of being more intrinsic as well as flexible than with their self-report. So a clinician, they utilize both their expertise as well as having some freedoms to dig deeper in terms of looking at history, looking at the client's thought processes or behavioral patterns, it allows us to be able to provide relevant information in our evaluation regarding our client's mental status. It also provides us with the capacity to clarify things that might have been ambiguous in terms of a self-report, as well as dig deeper in terms of those situations that we find contradictory. So as far as our sophistication as a clinician in terms of understanding and knowing psychopathology and human behavior, there's the theoretical construct that would be more complex as well as sophisticated in terms of an instrument design that we can utilize in developing rating scales for the psychiatric disorders. Excuse me. So now on the flip side of this, when we're looking at negative issues, just like we had the problem in terms of client bias with self-reports, clinical rating scales are subject to interviewer bias, okay? And that can be equally powerful in what the results would be in a psychological evaluation. So in terms of how we learn, we utilize training sessions and videotape interviews that would hopefully work toward reducing any kind of systematic type of errors in regards to utilizing those instruments. But you still may have some interviewer bias, and we can never say it'll be completely eliminated. Additionally, the fact that a professional clinician is required to do an interview significantly will increase in terms of how we do it in cost effectiveness. Lay interviews, they can be, trained evaluators in a lot of cases, but in terms of how we utilize our skills as professionals and the level of competency, then you can see where cost of training, and of course you understand the cost of training, you know what you're paying for your education, but we have to take these things into consideration as well when we're looking at things such as interviewer bias and knowing whether or not the more competent person is doing the interviewing. Okay, so last but not least, we look at flexibility that's going to be designed within your interview, and more likely how will it shape and take. At one point in time, there'll be some procedural information that won't resemble the screening instrument at all, and you'll start to take on different dynamics in providing, a comprehensive diagnostic interview. You'll utilize both self-report instruments as well as clinical interviews that would help you to define your client's status as far as their diagnostic criteria. And it'll help you to facilitate that evaluation and being able to carry and use both approaches that would allow you to have a quantitative stance in regards to the framework in your psychological evaluation. Now, the big thing I want you to remember is that both approaches do work, okay? They both have their valid points to it. And in any particular situation, it's going to really depend on the nature of the referral question of your client, of why they're coming in the first place, so that you would have an understanding of what type of resources you would need at hand in conducting your psychological evaluation. So one thing, we talked about the assessment and looking at those modalities, but there are some issues, and like the problem of low base rates is one of them. So Neal and Rosen, and this is back in 1955, they reported in a psychological journal about how psychologists were sensitized to dramatic impacts of low base rates on the predictive validity of psychological tests. And pretty much the researchers, they demonstrated that attempts to be able to predict rare attributes or events even with valid tests, extremely valid, can still result in more misclassifications than correct classifications or diagnoses. And that's in regards with prevalence of the attribute or event being significantly low. So knowledge and understanding of the importance of these tests and the problems that might exist because of low base rates would be to, keep in mind that particularly during that time, very few people had the level of expertise that was necessary. Now, about a decade later, Vecchio, I'm going to spell that out, Vecchio, Vecchio, he discussed looking at the similar issues, having same type of difficulties in terms of low base rates. But because he demonstrated substantive aspects of the report dealt with the screening process in terms of medicine, he was able to reach a wider audience because he was able to get his work into the New England Medicine Journal. So with that, the result was they was able to gain more knowledge in terms of special relationships between low base rates as well as predictive validity in screening tests. And that went like wildfire and became widespread. To be more concise, that discussed the low prevalence really didn't affect all the aspects to test validity equally. And the impact of that is that the validity partition really dealt with excuse me, being able to correctly classify those positive type cases and having predictive validity that would concern those negative or cases that was non-existent with minimal affect due to the extremely low prevalence, even the tests with moderate validity performed in identifying negative situations. Now, when we talk about sequential screening, this is a method that was designed to kind of overcome low base rate issues that's referred to sequential screening. And more or less this paradigm, there's 2 screening phases as well as 2 screening tests that was utilized. So in phase 1, it involved a less refined type of screening where the main purpose was to just be able to correctly identify those people without a condition and eliminate them from consideration. So phase 2, now we're looking at the initial screening that also had a really primary effect of raising prevalence of the index condition in terms of the remaining cohort. During phase 2, there's a separate test that would be equal or more sensitive in terms of how it was utilized because the base rate of that index condition really was more significantly raised by the first screening in phase 1 and then used during the phase 2 process to show results lower with lower levels of false positive misclassification. So a hypothetical example of, well, instead of talking about the hypothetical stat, because I don't have the table, unfortunately. So I'm going to stop with the hypothetical example because there was a table that unfortunately no longer exists, which is not fun. But it discussed sequential screening as a strategy for being able to deal with the low base rates, okay? But in that screening, it looked at a highly valid type of instrument that demonstrated sensitivity and specificity of 0.90 in terms of large population cohort. And that sample size was like 10,000. And there was a prevalence rate of 4% within the index condition. So I would go into that further, but more or less I'll stop there because it really is hard to discuss and not have that nice chart that was a part of it. So I do apologize for that. But just know with sequential screening, it's essentially going to be zeros on high-risk type subgroups of populations of interest through a series of consecutive sleeves. And it allows for us to have the effect of eliminating from consideration those clients who would have low consideration for disorders, as well as at the same time raise the base rate for the condition that they may have that's demonstrated within that sample. All right, so that discusses those facets, and we'll move forward. All right, so in the video clip we saw earlier, we heard Rita Summer-Flanagan discuss how there's a neurological component attached to empathy. Researchers have recently been able to develop theories regarding what happens in different brain regions that's demonstrating empathic experiences. And pretty much it allows to summarize pretty much a large body of the research that's out there right now, showing that various brain regions and structures are seen to be activated when people experience empathy. Particularly speaking, we're looking at the insular cortex. That's a small structure that resides deep within the fissure that separates the temporal lobe from the frontal lobe, as well as the parietal lobes. And it's been linked to empathy experiences, as well as self-regulation and other compassionate counseling type responses that we seek from clients. In terms of the compassion meditation, also known as loving kindness meditation, this has been associated with neural activity as well as structural development, or the thickening of the insula. Specifically speaking, we're looking at how individuals have been able to engage in extensive type of compassion meditation and their insula thickening in being able to view or hear someone when they're in distress. This shows their experiences have been more insula related neural activity than those who didn't have any type of compassion meditation experiences. Now, there's been other research that was demonstrated a meta-analysis, and there's been several reviews written talking about how during cognitive emotional perception, regulation, as well as response, that several brain structures are being activated, and then the relationships from that are truly highly complex. But as we know, our brain is a very complex instrument in itself. But in terms of when we're speaking about the role of the insular, that being the anterior insular cortex for empathetic responding. So more or less, there's a lot of evidence out there right now that shows and demonstrates a crucial component to the insular cortex in terms of empathy. And specifically, we look at that anterior insular cortex, showing how the brain region, which demonstrates the Sylvanian fissure, is automatically going to be connected to other cortical regions, which would also impact one's moods. So at the looking at this neurological process, it's kind of allowing us to see that compassion, as well as other human activities that would help to promote empathy, will contribute to the brain's growth, so to speak, specifically that thickening of the insula, as well as enhance one's empathic responsiveness. All right, so now we're going to return back and look at therapeutic attitudes, okay? And this list, and there's a lot of information for this list to share, but we're looking at how communication should always be two-way, not just you or not just the client. We have to also address our attending behaviors, how we're sitting, how we're looking, how we're listening. That includes our visual contact, eye contact, the quality of our voice, tracking verbal tendencies, as well as body language. So when you think about the communication is always two ways, you have to look at the fact that as a human, communication always is going to be both sending and receiving. Okay, that's that two-way street. And more or less, the messages, it goes in both directions and it's usually simultaneously. So if a person is sending out information, our goal would be to be a good listener, or in terms of sending or receiving, receive that information appropriately. So you want to listen, be able to listen well as maintain composure, and there's an etiquette of allowing someone to speak fully and then speaking when it's a good time to. But you have to be able to do this in a balance so that as you're receiving it, you're simultaneously also sending information. So some ways that we do this is difficult. I'll give you an example. I love going to meetings where there's several people in the meeting, and you'll have some individuals who feel, depending on the situation, that they have to interrupt. They constantly have to interrupt, even before getting the full thought process of a person that is speaking. Not only is that rude, but you lose material that is quite necessary for whatever information you was attempting to receive. So our communication styles need to be constant, but it has to be interactive in a way that we're sending and receiving both verbal and nonverbal type messages, so that even when we're not speaking, we're still communicating in some form or fashion. So you want to be able to allow yourself the opportunities to take in all the information and allow the person who's speaking to get their full thought processes complete. When we cut a person off, like I mentioned, in terms of psychological testing, you might have lost a great deal of data that would help you in with diagnostics in terms of how you would proceed in developing a good psychological evaluation. So it's really important that we maintain as a good listener, composure. And that's the best way I'm going to leave it at that. Now, when we're talking about attendant behaviors, now this is the more active type of listening styles that we need to put into place, because it entails utilizing nonverbal as well as very little type of verbal behaviors to make sure that your clients are listening. And when I say that, it's where attendant behaviors is sometimes referred to more as encouragement at a minimum, but it allows clients to speak more freely. To be successful at this, though, Summers and Flanagan, they discuss how you have to incorporate respect as well as an interest in what it is that your client is talking about. And it's those type of positive attendant behaviors that you can see through just about all the theoretical orientations. This is one of those universal type of to-dos as a clinician. Know that attendant behavior, generally speaking, is going to be more nonverbal than verbal. And when we're speaking about that, Edward T. Hall, he discussed how communication is really only 10% verbal, and that 90% would be more of a cultural situation, in terms of, he claimed it unquoted as a hidden cultural grammar. Whereas there's been others who felt that it's at least 65% more of a message meaning that's nonverbal to verbal. But basically speaking, when we're utilizing either verbal or nonverbal messages, we still have to know that a client understands both. So it's important for us to communicate with our clients effectively, both verbally and non-verbally. So there is in your readings, you should see about 4 different categories that talks about attending behavior. And I'm going to just give some brief information on the 4 now, that being visual eye contact, vocal qualities, verbal tracking, and body language. So now with visual contact, here we have to be really keen, and we have to be able to understand the person that's sitting before us, because it's going to vary in terms of the culture of your client. There are some individuals who would find staring directly at them to be inappropriate, as well as some individuals to find, if you're not looking at them enough, that you're not paying them respect. So being able to sustain eye contact during an interview is important, but it's knowing how and knowing when to be able to do so, okay? Because we have to understand the client's needs in terms of their cultural values, their cultural beliefs, and their cultural systems. Whether the eyes is going to represent being authoritative, being respectful, being compassionate, how those are all the different dynamics that can be involved. So know that for some of your clients, such as the African American culture, Black culture, there's more direct contact, eye contact. And even though, let me stop and say, even within one's ethnic group or culture, you might still see some differences depending on how they were raised, because there are still, even within a cultural group, you have subcultures, and the differences. No one has all been raised in the same way, but research has been able to demonstrate, for the most part, some of these ways that we would have to consider in terms of using visual contact. So more or less, in terms of African American cultures as well as Caucasian cultures, you would want to consider using more direct eye contact, whereas with Asian and Native American cultures, as you would use less eye contact. And now, some of the Flanagan include and stated that for some African American clients, it would be less eye contact as well. But understand your client first and foremost. You want to gauge how they're looking at you. And this would allow you to kind of understand and know. If you have a client who's automatically going head down, then it might be a sign of disrespect if they look you dead in the eye. So you might want to be able to also play off of their visual cues that you receive from them in how you approach it. You may still use eye contact, but every once in a while you might want to think about glancing down or glancing away if you see what is being modeled before you. Okay. Now, in the textbook, I like what the textbook gives you. Make sure you read that 4.2. It gives you some multicultural highlights in terms of visual eye contact. So let's talk about vocal qualities. It's really, in terms of vocal qualities, you're going to be dealing with a person's paralinguistics, and that I'm meaning the level of the tone, the pitch, the rate, how loud they are, what type of inflections might be present or not present. And in terms of psychometrics, that can give you a clue as well, not only to the cultural aspects, but also if are there any particular pervasive issues involved. So you want to be able to listen for that, as well as fluency. These are all cues that we can utilize in terms of when we're doing psychological assessments. But you want to really consider what type of variables would affect clients and how they're using their voice. Is it because if a person is extremely loud? Are they loud because they are self-confident, or are they loud because they may have a hearing issue? So taking those things into consideration is really important. You want to know about the interpersonal influences that might tell you why they might speak the way they do. Was it where it's a cultural issue where you're not supposed to speak loud? Or was it an issue based upon parenting styles in which children were taught that you are not allowed to speak high, with high pitch or with any real emotion? Or is it, like I mentioned before, pervasive in terms of developmental issues where a person might be demonstrating signs of autism in which they have a monotone voice, and that inflection is really not present. So these are different things that you want to consider and looked at, because to be effective as a clinician, you want to be able to help establish a rapport, and using voice qualities will help you in terms of how they're communicating, their level of interest, the empathy that's going to be present. It'll help you in terms of looking at whatever problems or conflicts might be coming about based upon what you hear and see. So you want to be able to follow the client's lead in that sense as well. All right, so now verbal tracking. This is more or less kind of going back and talking about how your client's speech patterns are. And it's not really adding what you professionally or personally feel about what they're saying. Verbal tracking is allowing yourself to pace the client's response and being able to closely monitor the content that's given based on the client's speech. And in this situation, Summers Flanagan talked about how you really want to try to avoid leading in this particular situation. You want to be able to gain accurate verbal tracking, and sometimes that can be a challenge, particularly when you have a client that speaks non-stop and they just going and going and going and going. So it's where you might have to throw in some distractions, so to speak, so that you can get a good pace going with your client that can help you in terms of verbal tracking. Now, finally, we talked about this a little already, but I want to go back and speak on it again, and that's talking about body language. You know, it's really an important form of our communication, and we have to know that there are at least two aspects to body language, that being kinesics and proxemics. So when we're talking about kinesics, it's talking about the physical features. It's talking about how the person's body moves physically in terms of their body parts, like their eyes, their face, the way their hands or shoulders are going. And proxemics is looking more at personal space. Do the client understand when, you know, it's too close? Like right now, we have social distancing going on. So with that being said, say for example, you met someone on the street right now during the pandemic. Do they have an understanding about personal space is extremely important during these times, because if their personal space, if they see it being up close, then even when you're saying, okay, you should be 6 feet apart, 6 feet apart from them, if they do an estimation, would really be 2 feet, which would be too close. So we have to have that understanding, and we have to also consider the fact that there are environmental factors that would be involved in terms of how people were taught personal space. One of the things I'll never forget is a practice that I used to do working at Mississippi State Hospital with clients, because their boundaries in terms of personal space and proxemics was really skewed. So a lot of times this was the distance, which would be 2 feet. So in terms of helping a person who comes up before you, I'm sorry, my dog got my attention, but a person who is coming before you and it appears that their personal space, they're not being appropriate, you're probably going to want to say, okay, I need you 6 feet back, and express that both non-verbally with body language as well as verbally. So you'll probably have to utilize several tools. But it's important for you as a clinician to also understand your proxemics. How close are you? Sometimes the way a room is done, you might find yourself much closer to your clients than your clients would feel comfortable being. So it's important for us to be able to gauge that, because sometimes you need to sit back when you see that your client is kind of recoiling from you because you're all the way up like this. So again, it's about gauging and balancing those. Main thing I want to say about body language as well is that we know that our body language is a form of communication. And in speaking about when we talked about Roger's approach in terms of client therapists, we have to look at it just like I mentioned in terms of how we do seating arrangements. We have to kind of look at conflicts that can develop because of your body language. One of the things, my theoretical orientation, of course, is in psychodynamics. And one of the things that used to, as far as being a student when I was attending graduate school, was that I had a professor, Dr. I'm going to give her name, rest her soul, but Dr. Schlesing, she you could not sit in any type of way or form without her analyzing what was going on. And she would literally, during class time, when we are supposed to be talking about psychotherapy, stop in the middle of psychotherapy and question the student in regards to their body language. If the client, as a student, I think there was one time, I'm one of those individuals that have pervasive developmental issues, and so because of that, sometimes I'm indifferent looking, and even when I'm paying attention, I appear indifferent. So I think there was one time I was actually going like this at my desk, and she's like, "Am I boring you?" And I'm like, what? Because I really didn't pay attention to the fact that I was like this. So she was like, I must be boring you and you're really not interested in the things that I'm trying to teach you today. And I'm like, I'm fully in attending and I'm fully listening and I'm trying to take in everything that you're speaking about. But she was actually really upset with seeing my hand on my face like that. Another time was don't slouch in her class, because she got on a student about slouching. That it meant that, that you wasn't respecting her as a person, and she went through everything. So by the time we finished our training, body language was really in the forefront of us being aware about how we sit during therapy sessions and how we react and how we should be acting and looking. And like I mentioned before, even with the training, it was still where it takes practice. It really do, because a lot of our body language is something that is learned and had been taught to us throughout the years, that we used for many years, and even in a professional stance, we still are who we are. So you have to take those different type of things into consideration. So right now, I'm actually was hoping to get through the entire 2 chapters. I'm actually going to stop here, and the reason why is because you also have a little bit of fur that you'll be going over in terms of dimensionality that I want you to see. And then to equal out your assignment, it's going to take up the other hour and a half. So you have approximately 90 minutes of hearing my wonderful voice, and then you're going to have an assignment that's the additional 90 minutes in which you'll have questions that I would like for you to answer. There's an article that's attached, as well as a little video clip that I want. It's a fictional, let me say that first and foremost. I don't know if you ever watched Station 19, but Station 19 last week came to me and I was like, I love it. I want to show this and I want to get the students' perspectives. It was my hope that we was going to do that via live conference, but that's okay. You can still see the clip and utilize that clip, and hopefully it'll help get you thinking, get your mind straight. So the next thing you're going to be looking at is my lecture on FERS work on dimensionality. Then there'll be a link at the bottom of the page taking you directly to the assignment. On that note, I'm long-winded at this point, so I'm going to stop here. I will be completing and adding from this chapter. I'm going to probably add it on and amend next week's with it, so it'll have a continual flow and you'll still have the rest of the listening chapters. On that note, y'all enjoy the rest of your week and y'all take care.